lecture K.S. Subramaniam PG Free Paper Award Session 2. Our judges are ready with us, Dr. Chandrasekhar D, Dr. Vijay Raghavan BR and Dr. Kausalya. So I invite the first speaker, Dr. Radhika Anil Kumar, Free Paper 130.
Okay, ma. Start. Timer put. Yes, doctor. Start.
Good afternoon. I am presenting a paper on optical coherence tomography angiographic features of diabetic macular edema. The aim of the study is to characterize OCTA features in DME, comparing them across people with diabetic retinopathy without DME and control groups and exploring their clinical implications. It is a prospective interventional study done with 90 participants categorized into people with DME, people with DR without DME and controls. It was studied across 12 months at a Department of Ophthalmology at a quaternary care center. The inclusion criteria included 18 years or older, DME confirmed by OCT with a central macular thickness of 250 microns or more, with type 1, type 2 diabetes mellitus with evidence of diabetic retinopathy and with a willingness of follow-up. The exclusion criteria included people with less than 18 years of age and those with coexisting ocular conditions that would confound OCTA interpretation, such as significant media opacities, advanced glaucoma, or other retinal pathologies aside from DME. We have taken an informed consent, did a baseline demographic and clinical data with age, gender, status of diabetes mellitus, and done a comprehensive ocular examination. The OCTA imaging was conducted to visualize and quantify retinal microvascular changes, while SD-OCT measured the CMT and the presence of intraretinal or subretinal fluid. Participants with DME were given intravitreal injection of anti-VEGF and monitored through monthly follow-up visits to track the changes in OCTA parameters and evaluate treatment response. The OCT angiographic parameters included were the vessel density, vascular perfusion density, and foveal avascular zone as given in the ETDRS grid seen here. The outcome measures. The primary outcome measure of this study is the quantification and characterization of OCTA features associated with diabetic macular edema. Secondary outcome measures include evaluating OCTA-derived features to predict a favorable response to anti-VEGF therapy for DME. Moving on to the results. Of all the participants in the three groups, it is seen that the age group, the most common age group was 50 to 60 years of age, which is not of any statistical significance. Moving on to the analysis of the baseline visit, it is seen that the foveal avascular zone was the most in the DME group and the least in the control group, but not of statistical significance. It is also seen that the vessel density in the superficial capillary plexus, the value was the most in the control group with the least in the DME group, but not of statistical significance. In the vascular perfusion outer parameter, it is seen that the value was most in the control group with the least in the DME group and of statistical significance. It is also seen that the vision was better in the control group and poorer in the DME group. Moving on to the longitudinal OCTA assessment in DME patients across subsequent visits, it is seen that the foveal avascular zone was increasing throughout the subsequent visits with a statistical significance, and vessel density, central and inner parameters were also seen to be increasing across the subsequent visits, whereas the vessel density in the full and outer parameters remained almost constant, which are of statistical significance. It was seen that the vascular perfusion in all the parameters were seen to be increasing across the subsequent visits, and vision also became better, all of statistical significance. Prognosticators of presence of DME, it was seen that the foveal avascular zone area, perimetry and circularity had a positive beta coefficient with odds ratio more than 1, indicating that larger the area, higher the odds of having DME. Also, vessel density, full, inner and outer, had negative coefficients with an odd ratio more than 1, signifying that lesser the vessel density, more the chance of DME. Moving on to the discussion. It was investigated that our study investigated the Octa's ability to characterize and understand DME across the parameters such as foveal avascular zone, vessel density, and vascular permeability. Our findings are in line with previous studies highlighting Octa's role in detecting structural and functional alterations in DME. Our study confirms trends observed in studies by Lee et al., Zhang et al., and Mirshahi, who reported similar demographic profiles and Octa features. The study showed poorer visual acuity in DME patients, consistent with Wang et al., which showed Octa's importance in evaluating visual outcomes. Comparative analysis revealed that Octa parameters such as enlarged foveal avascular zone, reduced vessel density are associated with DME presence, supporting findings by Sun et al. And Atta Allah et al. OCTA's capacity to capture detailed microvascular changes is crucial tool for early diagnosis and treatment monitoring in DME. Future studies should focus on standardized methodologies and larger cohorts to further validate these findings and enhance clinical practice. The limitations of the study was that it had a small sample size. Although adequate for initial comparisons, our sample size have limited statistical power for detecting smaller differences or conducting stratified analysis by disease severity. It is a single center study, so it is studies findings influenced by specific patient demographics, clinical practices, and imaging protocols. It is a cross-sectional analysis, it was restricting our ability to establish a causal relationship between Octa findings and disease progression. Also, many of the patients were non-compliant for follow-up for various reasons. Concluding, there were significant changes in Octa features. Significant changes in Octa features were found in DME when compared with people in the two other groups. It is seen that areas of larger foveal avascular zone and lower vessel densities are associated with higher odds of DME. With treatment, the vessel density and vascular perfusion improves. Integrating Octa into routine clinical practice holds immense potential to refine early diagnosis, optimize therapeutic interventions, and improve visual outcomes for patients with diabetic retinopathy. Thank you.
Did you do SDOCT for all these patients?
Yes, sir.
But you're not mentioned in your results. Comparatively advantage? No.
Sir, we have taken people with DME as per the CMT thickness got in a SDOCT, sir.
So that you have not mentioned?
Only in a methodology, sir, I've mentioned that.
No, not in the results?
No, sir.
Okay, thank you.
Okay, thank you, sir.
Our next speaker is Dr. Shweta S. Raj, free paper 114.
Good afternoon. My paper is a real-world data on progression of diabetic retinopathy. We started the study with the aim to look into the changes in best-corrected visual acuity, diabetic retinopathy stage, and treatment approaches between the baseline visit and the follow-up visit. All adult patients who presented at Amrita Institute of Medical Sciences, Kochi, diagnosed with diabetic retinopathy and gave consent to be a part of the Government of India BIRAC registry were taken into this study. It was a cohort study of 493 patients over a duration of 24 months. At baseline visit, the visual acuity and stage of DR were documented. In patients with proliferative diabetic retinopathy, FFA, and followed by intravitreal injection of anti-VEGF agents and panretinal photocoagulation was done. In patients who had vitreous hemorrhage or tractional retinal detachment, pars plana vitrectomy was done. At the end of 2 years, we again looked into the visual acuity, diabetic retinopathy status, and the interventions that we did over the 2 years. The patients who failed to comply with all these advices were called, they were explained the need for compliance, and the reason for non-compliance were documented. Baseline data was of 493 patients. We had 146 females and 347 males. 70% of the population was in the age group of 45 to 65. And the site-threatening DR that includes proliferative diabetic retinopathy, laser PDRs, and diabetic macular edema were the majority, which was 529. And at the end of 2 years, we noted that 194 patients were adhering to follow-up. Again, 65% was males, 67% was in the age group of 45 to 65, and less than 20 years of diabetic mellitus in 72% of the patients, which was similar to the baseline data. By the end of 2 years, around 60% have remained stable, but 40% had progressed with vision-threatening changes and needed active intervention. When we looked into the visual acuity change, it was seen that at around 1 year, there was a slight drop in the visual acuity, but by the end of 2 years, we were able to reach a visual acuity that was slightly better than the baseline visual acuity. As a subgroup analysis, when it was checked, the treatment naive PDR showed a progression that 30% was progressing to vitreous hemorrhages or tractional retinal detachments. In status post vitrectomy patients, at the end, in the first year, 66.7 had a stable or improved visual acuity, and by the end of 2 years, 70% could preserve their vision. So as I have told, we had called these patients and taken up the reason why they were not complying. They gave multiple reasons like difficulty in traveling, financial issues, systemic illness. One eye already lost, so they didn't want to progress for come for the treatment of the other eye, and various such reasons which we thought is important to look into. Coming to the discussion. 43.9 presenting with the treatment naive PDR significantly points out the need for more screening and public education programs for diabetic retinopathy. 40% progressing to vitreous hemorrhage or tractional retinal detachments, that they are the vision threatening complications, indicating that we need to have a faster pace because diabetes mellitus and diabetic retinopathy is progressing at a faster pace, so we should also buck up. 80% of the study participants have benefited from the treatment, 57% had experiencing stable visual acuity, and 22 having an improved visual acuity, underscores the effectiveness of the interventions implemented. And patient compliance, the reluctance to accept the poor prognosis nature of the disease and the long duration of treatment and follow-up is pointing at the ignorance among common people about diabetic retinopathy. This was not just the situation in India alone, but Ramaswamy et al. Did a study, and he found that patients were cognizant about diabetes mellitus, but understanding diabetic retinopathy and its implications were poor. Multiple studies internationally in Austria and all, they tried to negate the financial issue by providing them insurance, but still the compliance was less. So the limitation of this was the high attrition rate in the number of people who came for follow-up, and we did not, the multiple confounding factors like ocular diseases, systemic conditions, and other ocular interventions or medications that could not be eliminated completely. Concluding, regular follow-up and timely intervention significantly improved the visual outcome of 80% of our study participants. 40% progression of diabetic retinopathy shows that the vision-threatening nature of diabetic retinopathy warrants a close follow-up of the patients. To tackle diabetic retinopathy, a personalized approach is needed to educate the population about the sight-threatening nature of DR, the irreversibility of the damage, and the ideology behind the treatment strategies that we are advising. With the development of social media and artificial intelligence being incorporated into medical sector, we can improve patient education, compliance, and monitoring. Thank you.
Nice, madam. But you told patients are didn't come for follow-up because they lost one eye. I do not know the reason.
Sir, actually I personally had called and talked to these patients. So one eye was tractional retinal detachment and the other eye was severe NPDR, for example. So the patient considered one injection or one sitting of laser as a treatment that is over. They didn't want to come for the next follow-up. They were like, I have already taken treatment in the one eye, why, and nothing happened, no changes there, I lost my vision, why should I come for the next eye and spend my money? That was the question I had to face.
That means some counselor should have been there, then only they can advise.
Sir, each of these patients, because for this registry, we had explained to them that they have to comply, they have to come, and this is a long-term disease. Everything was explained to them, but maybe the age of the patient, like elderly patients, are reluctant to understand the debilitating disease. Maybe that is one of.
One more thing, your slides, you're writing so many sentences in single slide is not
Okay.
something not attractive.
Okay, sir.
And moreover, all in block letters, capitals. You're not supposed to. It looks doesn't because slides also carry marks here.
Okay, sir. I'll make
Okay,
the
thank
changes. Thank you, sir.
Thank you. Go ahead. Just a reminder, all of you know it is a 6-minute presentation. So finish before the final. At the end of 5 minutes, you will get a warning sign. So try to finish. All the best. Next.
Dr. Athira Gaudaman, free paper 111.
These 3 people have a parallel poster presentation, so they are coming ahead. Then we'll go according to the.
Good afternoon all. Today I'll be presenting my paper titled Knowledge, Attitude and Practice Pattern of Contact Lens Wear Among Medical Students. Around 140 million people are using contact lens worldwide. As the number of contact lens wearers are increasing, assessment of knowledge and attitude regarding contact lens wear can aid in understanding the deficits and strengthen those areas when it comes to practice. My objective is to assess the knowledge, attitude and practice pattern of contact lens wear among medical students. This was a cross-sectional study conducted among 75 MBBS students including interns using a well-structured questionnaire. This is my questionnaire containing 4 sections, with section A containing 8 questions on demographic and general details, section B containing 12 questions on knowledge, section C contained 13 questions on attitude, and section D with 13 questions on practice. And it was scored as excellent, good, average and poor. P less than 0.05 was considered significant. Out of 75 participants, 27% belonged to final year and 16% were interns. 59% belonged to the age group 19 to 22 years and 41% belonged to 23 to 25 years. 97% were using soft contact lenses, 83% were occasional contact lens users, whereas 17% were regular users. 57% were using monthly disposable lenses, 29% were wearing daily wear type, and 15% were wearing weekly disposable lenses. Duration of contact lens use, 53% were using for a duration of less than 1 year, whereas 11% were using lenses for more than 4 years. 57% were using lenses for refractive error correction, whereas 43% were using mainly for cosmetic purpose. 73% of the students had purchased contact lenses online at least once. Barriers of using contact lenses regularly by occasional users, 44% had satisfaction with spectacles, 42% had fear of side effects, 13% had cost constraints, and 1% had lack of adequate information. Daily duration of contact lens wear, 56% were using for less than 8 hours daily, and 11% were using for more than 16 hours. On assessing knowledge, 97% students knew that washing hands is important with soap before and after handling contact lenses. 88% knew that cleaning of contact lenses is important before and after use. 68% knew that ideal daily hours of usage of contact lenses. 92% knew that lens solution has to be used for cleaning contact lenses. Only 31% knew that lens case has to be cleaned daily. 52% only knew that 3 months is the ideal duration of use of contact lens solution after opening the seal. Overall knowledge was good in 53%, average in 44%, and poor in 3%. Upon assessing the attitude, 96% felt that it is important to wash hands before handling contact lenses and to use lens solution for cleaning lenses and to consult an ophthalmologist if any eye symptoms occur after using the lenses. Overall attitude was excellent in 69%, good in 20%, average in 10%. Upon assessing the practice, 98% were washing hands before and after handling lenses, 82% were cleaning lenses before and after usage, 16% had used tap water to clean the lenses at least once, 8% were using lenses during sleep, 19% were using contact lens solution beyond expiry. Upon as overall practice pattern was excellent in 42%, good in 37%, average in 16%, and poor in 4%. There was a positive correlation with p-value less than 0.001, which confirmed that positive attitude is associated with better practice outcomes. No statistical significance was seen between knowledge and attitude scores as well as knowledge and practice scores. In our study, almost all the participants had practice of washing hands before handling the lenses, similar to other studies. 82% of students clean the lenses before and after use, similar to that in the study by Mahima et al., where it was 100% in the study by Purushottam et al. Students use tap water to clean the lenses at least once in our studies at 16%, which was similar to studies by Mahima et al. And other studies, whereas it was only 5% in the study by Janti et al. In our study, the students who use contact lenses for more than 8 hours daily were 44%, which was comparatively lower than that in the study by Venkatesh et al. Students who slept with contact lenses on was found to be 8% in our study, which was in contrast to other studies. Only 52% were aware that lens solution can be used for 3 months once a seal is broken, which was similar to the study by Venkatesh et al. In our study, 73% students were purchasing lenses online, which is a concern, suggesting that even students with good knowledge does not appreciate risk of online purchasing. Although there are several KP studies on contact lenses among medical students, the studies assessing correlation between knowledge, attitude, and practice patterns were not available. In our study, we found that positive attitude is associated with better practice outcomes. Even in knowledgeable users like medical students, there is lack of proper practice in spite of good attitude, which can increase the risk of complications associated with the contact lens wear. This can affect the knowledge they provide to the general population as a future care providers. So there is a need for targeted education interventions regarding proper contact lens use, hygiene and complications among medical students to ensure safe contact lens use practices. These are my references. Thank you.
Good presentation. Again, as sir told for the previous speaker, your slides have to be better.
Yes, ma'am.
And font size you have to take care of. And also the background colors which you are using. No, you are using very light colors, pastel colors.
Yes,
You should be using little darker, brighter colors. Yes, okay, that is one thing. And about the questionnaire, where did you take the questionnaire from? That you have to mention.
Okay, ma'am.
Where was it taken?
Ma'am, from the previous studies, from the previous knowledge attitude practice studies, I've taken the questionnaire.
Have you taken permission to use that questionnaire? Because you are supposed to get permission from the person who has developed that questionnaire before doing a study. Was that done?
Okay, ma'am. No.
Okay, that has to be taken care of.
Okay, ma'am.
And you must also acknowledge them. Thank you.
Okay. Thank you, sir.
How many of you are representing the speaker because the speaker could not come? Or is it all speakers only who are going to present? Sure? Okay. Thank you, ma.
Next is Dr. Anu Joseph Babu, free paper 10.
Good afternoon all. My topic of presentation is central corneal thickness in myopic children and young adult, a hospital-based cross-sectional study. Coming to introduction, cornea is a principal refractive surface. Normal corneal thickness at the center is 0.52 mm. It ranges from 0.49 to 0.56 mm. Myopia is the most common refractive error. Ocular rigidity is said to play an important role in the pathogenesis of myopia. Cornea and sclera together forms the outer fibrous tunic of the eye and withstand both internal and external forces to maintain eyeball shape. Whether a change in the biomechanical properties leads to axial length elongation and anterior chamber deepening, which subsequently result in decreased scleral or corneal thickness and elasticity, remains controversial. So there are various studies comparing myopia and central corneal thickness, and different studies shows different results. Some studies shows that it has a thicker CCT in myopia patients, some shows that there is a thinner CCT in myopia patients, and yet another study shows that there is no correlation between myopia and central corneal thickness. And also, CCT is an important measure for selecting various refractive surgeries. So, we embarked on this study to establish whether there is any association between myopia and CCT in our region. So, the primary objective was to determine the central corneal thickness among myopic children and young adults attending the ophthalmology OPD in Government Medical College, Thrissur. And the secondary objective is to compare the central corneal thickness among various degrees of myopia and to study the association of CCT with the age and gender of the participants. And coming to materials and methods, study design, it was a hospital-based cross-sectional study. The study setting is in the Department of Ophthalmology, Government Medical College, Thrissur. Study period, the study was conducted over a period of 1 year, and the study population was children from 8 years and young adults up to 35 years attending the ophthalmology OPD during the study period with a diagnosis of myopia were approached for the study. And our inclusion criteria was children from 8 years and adult up to 35 years and those who give consent. Exclusion criteria was astigmatism of more than 1.5 diopter, ocular trauma, ocular surgery and ocular infections. Sample size calculation was done based on the study conducted by Soluti et al. And it was found to be 126. And the sampling technique was consecutive sampling and the study instruments were retinoscope, anterior segment OCT for central corneal thickness measurement. And the study procedure was all the subjects underwent slit lamp examination. Those with the corneal scar, corneal edema, keratitis and other ocular infections ruled out. Study analysis data entered using MS Excel, analyzed using IBM SPSS 26 version software, quantitative data measured using mean and standard deviation, and the student t-test used for quantitative analysis, and p-value of less than 0.05 was taken as statistical significance. And qualitative data was analyzed using chi-square test and correlation between CCT and other variables assessed using Pearson correlation. Coming to results, a total of 126 cases were included in our study, and out of which 48 were males and 78 were females. And our mean CCT was 542.5 plus or minus 14.2 micrometer. And in mild, moderate and severe myopia, mean CCTs were 544, 542 and 537 micrometer respectively, and with a p-value of 0.3, which suggests that there was no statistically significant difference between the central corneal thickness in various degrees of myopia in our study. And also comparing CCT versus gender, in males it was 541 and in females it was 542 micrometer, and the p-value was 1.16, and it also suggests that there was no statistically significant difference in the CCT between males and females in our study. And also compared CCT versus age, and it also shows that there was no significant difference in the CCT between various age group in our study. Coming to discussion, in our study the mean CCT was 542 plus or minus 14.2 micrometer, and similar study conducted by Galappa, Divya K, Ganesh MR in South India, SB Pham et al. And SW Chang also got similar mean CCT values. Comparing CCT versus gender, in our study we found that there was no statistically significant difference, and similar study done by Hussainad also shows no statistically significant difference. But a study done by Kim et al. In China, they found that there is a higher CCT in men than in women with a significant p-value of 0.003. And comparing CCT with the severity of the myopia, in our study there was no statistically significant relation between CCT and severity of the myopia, but also a study conducted by Lalit Sundaram and HB Pham et al. Also shows that there is no statistically significant relation. And comparing CCT versus age, in our study it was not statistically significant, and similar study done by Chen et al. Also shows no statistical significant relation. And coming to the conclusion, the study demonstrated that the mean central corneal thickness in myopic children and young adult was 542 plus or minus 14.2 micrometer in our region, and the study concluded that there was no statistically significant difference between the CCT and severity of the myopia. It thus shows that there is no significant thinning of myopic cornea in a similar way to sclera during myopic progression, and there was no statistically significant difference in CCT between different age group, gender, and it does not show any correlation with the patient's age, gender, and severity of the myopia. And the limitation of our study was, this study was conducted in a single hospital, and study with a more sample size is needed to confirm the findings. Thank you. It shows that there is no significant thinning of the cornea like sclera in myopia from my study.
Thank you.
Next is Dr. Lisbeth Tom, Paper number 13.
Good afternoon. Profile and determinants of macular ganglion cell inner plexiform layer thickness in South Indians. Ganglion cells being the final output neurons of the retina, they are essential for maintaining vision, and thinning of this crucial layer is associated with various neurological diseases like multiple sclerosis, Alzheimer's, Parkinson's, and also in glaucoma. But there is a wide variability in normal thickness among various studies, and there are limited studies in South India, especially in Kerala. So the aim of the study was to find out the normative data and determinants of macular ganglion cell inner plexiform layer thickness in South Indian population. And the objectives of the study was to find out the normative data among patients attending the OP in a tertiary care center and to find the association with various demographic as well as lifestyle and neurodegenerative risk factors on GCL-IPL thickness. This was a cross-sectional hospital-based study in ophthalmology OP in a tertiary care center spanning over 1.5 years, and the sample size calculated was 168. Patients above 18 years with a west curtal visual acuity of 20/20 with refraction within plus or minus 5 diopters sphere and plus or minus 2 diopters cylinder were taken. And those who were excluded were systemic or neurological diseases that might affect the retinal architecture, or ocular disorders like glaucoma, ongoing inflammation, any previous intraocular surgery or laser treatment, or any factors affecting OCT signal strength like media opacity or non-dilating people were excluded. After obtaining informed consent, demographic data was taken, then systemic history including diabetes, hypertension, history of smoking, alcoholism, digital screen time was taken, then vision and anterior segment were assessed, and IOP was measured using Goldman applanation tonometry, and pupil was dilated and fundus evaluated. OCT macula was taken using a spectral domain OCT and using the ganglion cell analysis algorithm. The distance between inner border of GCL and outer border of IPL was taken. Coming to the results, among the 168 sample, 55% of females and with the median age of 47.5 years, majority, that is 26% were less than 30 years, 40% were diabetics and 21% were hypertensives, 6% were smokers and 22% consumed alcohol, with majority of the sample was having a digital screen time of 2 to 5 hours. The mean GCL-IPL thickness from the study was 79.49 plus or minus 6.373 microns. Males had slightly higher GCL-IPL thickness of 79.79, and females had 3.86 times odds of having GCL-IPL thickness less than 80. It was found from the study that GCL-IPL thickness decreased significantly with age, and patients with age more than 47.5 years had 13.5 times odds of having GCL-IPL thickness less than 80. A negative correlation of GCL-IPL thickness with age was noted, with 0.151 micron decrease per decade of life. And there was significant thinning of the GCL-IPL thickness in diabetics and hypertensives, with diabetics having a 2.72 times odds of having GCL-IPL thickness less than 80. A negative correlation was also noted between the duration of diabetes and GCL-IPL thickness, but this was not statistically significant. From this table, we can see that a 60-year-old female who is diabetic and hypertensive for 10 years have a severely thin GCL-IPL thickness compared to a 24-year-old male with no other comorbidities. Significant difference in GCL-IPL thickness according to digital screen time was also noted, with thinning in patients more than screen time more than 10 hours. Though smoking and alcoholism caused GCL-IPL thinning, it was not statistically significant. To conclude, the average GCL-IPL thickness obtained was 79.49 plus or minus 6.3 microns, and the determinants were age, female sex, diabetes, hypertension, and digital screen time. This study provides a reliable reference normative data of the South Indian population, that's Kerala population. And in diabetics and hypertension, in this study, it says that GCL-IPL thinning preceded fundus and OCT signs of retinal microvasculopathy, which has great implications in retinopathy screening. And to our knowledge, this is the first study in which digital screen time has emerged as a possible modifiable determinant of retinal neurodegeneration. The association of GCL-IPL thickness and digital screen time need to be studied further, with proper history of the device being used, any blue filter was used, any distance from the device, quality and the make of device, etc. should also be considered. These were my references, and thank you.
It's a nice study. It's innovative. I think you should
tell some of your friends in other states also in South India to do, and we can compare. So that's how it should be done, I think.
Actually, it needs to be studied further. We have it as a accidental finding somewhat, like the DC library thinning is seen with increased digital screen time. So it should be studied further to know the correlation between them.
There are no other references for the study?
For the digital screen time, there are no other references, but for other diabetics and hypertensive, there are multiple references.
Thank you.
Thank you.
Okay, next is Dr. Nandini P. Das, free paper 16.
Good afternoon. I am here to present my study topic on the utility of cerebral visual impairment inventory in screening among children attending Regional Early Intervention Center in a tertiary care center. So the term cerebral visual impairment implies that the site of visual impairment is present in the parts of the brain that process the visual information. The damage to the dorsal and ventral stream is responsible for the clinical features of CVI. So it is a spectrum ranging from low function CVI to the high function CVI. So the recent trends has shown that increased survival of high risk newborn has increased the risk of CVI along with other neurodevelopmental conditions. It is one of the emerging causes of visual impairment in India. It is underdiagnosed and underreported in India. So we must be equipped to manage these children. A structured screening questionnaire relating to child visual function help in eliciting the signs and symptoms and is cost effective for screening larger group at risk. No validated instrument for screening is available locally. The objective of my study is to assess the effectiveness of CVI questionnaire based upon the Dutton Insight Inventory for early screening and compare with clinical examination. Also to study the common neurodevelopmental condition associated with CVI. The study design used is a diagnostic test evaluation conducted at REIC Department of Ophthalmology, Government Medical College, Thrissur. The population include all children of neurodevelopmental condition referring to the REIC and attending the CVI clinic for a period of 1 year. The inclusion criteria, the child aged from 4 to 15 years with neurodevelopmental condition and no obvious visually accountable ocular pathology. Children who had previously received advice on specific habitational strategies, parents not willing to give the consent were excluded from my study. The sample size was 100. This was calculated from the sensitivity of CVI by the Aishwarya et al. Study with 95% confidence. Study procedure. After taking the informed consent, the following demographic details like age, sex, associated neurodevelopmental condition or any radiological investigations were noted. Followed which a translated and a validated version of Dutton's Insight Inventory containing 51 questions were given to the parents for the screening of the children, and then these children underwent a detailed ophthalmological evaluation and special test for CVI. The study tool includes a translated and validated version of Dutton Insight Inventory in Malayalam. So each question is rated on a 5-point scale ranging from 0 to 5, that 0 means never, 4 is always and 5 is not applicable, and mean scores were calculated. A positive result on 3 or more questions is considered positive for screening of CVI, and these were clinically correlated. A comprehensive ocular examination is done including the fundus examination and dynamic retinoscopy. And this is a CVI clinic of our department, and these are the tools we used in our clinic. And the special tests for CVI include the LIA mailbox and LIA 3D puzzle. The diagnostic criteria for CVI is visual loss not explained by the ocular examination or having any associated neurodevelopmental condition or presence of a unique visual and behavioral characteristics. How we diagnosed is that presence of one of the unique or visual behavioral characteristic along the other one of the 2 diagnostic criteria which I mentioned earlier. So these are the 10 characteristics of CVI, and these are the 2 examples like glide gazing and difficulty near vision. And to obtain the cutoff value for the Dutton Insight Inventory for predicting CVI, the following parameters were calculated and were clinically correlated. Coming to the result, out of 100 children with neurodevelopmental condition, 59 were diagnosed to have CVI, and among that, low function CVI was 39, which was profound CVI, and high function CVI was 20.
The distribution of participants based upon the diagnosis of CVA by insight inventory, if they scored 4, that is always in 3 or more questions, 21 were diagnosed with CVA, and clinically 59 were diagnosed to have CVA. So this is a distribution based upon the special characteristics, and diagnostic accuracy of the insight inventory were calculated by using a 2:2 table. We calculated the sensitivity, which was 33.9%, and overall diagnostic accuracy was 16.4%. The most common neurodevelopmental condition was hypoxic ischemic encephalopathy. So in this study, I present the evidence of predictive value of the CVA questionnaire. So comparison with similar studies is, in my study the sensitivity was 33.90% compared with that of the Aishwarya et al. And E. Orbiter study, which was much less. The probable reason of low sensitivity of the questionnaire may be large number of the children of my study group was low function CVI in whom the responses were not applicable, or maybe the prospective nature of the study. Coming to the conclusion, in this study, the CVA questionnaire was not found to be much effective as a screening tool due to low sensitivity in our study population. Larger trials may be required for further validation of the CVA questionnaire. And the most common neurodevelopmental condition was hypoxic ischemic encephalopathy. The limitation of study, majority of the children were low function CVA, which was profound CVA, and limited sample size and limited duration of the study. So I would like to conclude by saying that early screening and intervention of the CVA may improve the visual outcome of these children. So a valid screening tool is helpful for them. Thank you.
What is CVA?
Sir, it's a cerebral visual impairment.
Have you mentioned the expansion in any of your slides?
Sir, in the first title page only I have.
And
in the
can you put the
introduction
slides,
also.
please? One nimisham on the slide. What is CVA?
Cerebral visual impairment.
That's what?
So in the introduction slide I have mentioned.
In the first slide. Can you go move the slide to, you said some tests are being done in our clinic. Go ahead. Okay. Next. Oh, go back. All the 4. No. Next one.
Back.
No, the four slides you showed. No, that one. Next one. All are taken in your clinic only.
Yeah, yes, sir.
Okay.
Thank you, sir.
Next is Dr. Angita Rose Matthew, free paper 28.
Good afternoon. My paper is on observational study on the proportion of retinopathy of prematurity and its clinical cause. ROP is a disease of retinal vascular and capillary proliferation affecting preterm infants. It is a potentially blinding disease if not diagnosed and treated early. Incidence of ROPs have been increasing in developing countries over the past 2 decades with advancement in neonatal care. There are several risk factors, including maternal and infant factors, which contribute to the development of ROP. ROP diagnosed infants have to be followed up regularly for progression and regression, and treatment is given according to National Neonatology Forum 2020 guideline. Most of the ROPs usually regress with complete development and development of retinal vasculature. Here in my study, my objective is to find the proportion of ROP and to assess the clinical cause among ROP detected infants. It is a prospective observational study done in the Department of Ophthalmology, Government Medical College, Kottayam, during a period of 12 months after getting approval from Institutional Review Board, in a population of preterm newborns presenting to the Department of Ophthalmology who satisfied the inclusion criteria, who satisfied the National Neonatology Forum 2022 guideline. Those infants who lost to follow-up during study period without development of ROP or before complete vascularization of retina were excluded, and those having media opacities due to congenital anomalies like congenital glaucoma, congenital cataract, retinoblastoma were also excluded. 140 infants who satisfied the National Neonatology Forum 2020 guidelines were screened. Informations were collected through structured performa. Anterior segment and pupillary examination was done. Fundus examination was done under topical anesthesia and with phenylephrine tropicamide combination eye drop. Using a Flens-Creel depressor used to visualize the retinal periphery, and complete fundus examination was done using indirect ophthalmoscope and 20D lens. ROP detected infants were classified based on ICROP guideline. Follow-up examination was done up to complete vascularization of retina of both eyes of the infant. Coming to the results of my study, out of 140 infants screened, 35 infants, that is 25% had ROP. Two newborns, that is with 4 eyes, had a sluggish pupillary reaction with poor pupillary dilatation, had stage 3 ROP with plus disease in the initial presentation itself. ROP detected eyes in the initial presentation. 18.6% had normal fundal finding, 42.9% in stage 1, 27.1% in stage 2, 10% in stage 3, none presented in stage 4 or stage 5, and one eye, that is 1.4% presented with AP-ROP. Most of the ROP detected infants belong to stage 1 in the initial presentation, none presented with stage 4 or 5, one baby presented with AP-ROP disease. Plus disease was present in 2.1%, that is 3 eyes. ROP was commonly seen in zone 2 in my study. Most of the babies detected with ROP belong to 28 to 32 weeks of gestation. Most of the babies presented for screening belong to birth weight between 1500 and 2000, and ROP was detected in babies having birth weight between 1000 and 1500. There is no statistically significant difference between male and female gender in ROP detected infants. Coming to the risk factors in ROP detected infants, we studied multiple gestation, pregnancy-induced hypertension, gestational diabetes mellitus, respiratory distress syndrome, congenital heart disease, bradycardia, interventricular hemorrhage, sepsis, anemia, and apnea. Of these, only RDS and sepsis showed a statistically significant association. These are elaborated separately. Of the ROP diagnosed infants, 4 eyes remained normal till the last follow-up. None of the infants presented with stage 4 or 5. Infants with AP-ROP was treated with anti-VEGF and laser once diagnosed. All the ROP detected eyes showed regression from the second visit itself. On the final follow-up, ROP was regressed in all the ROP diagnosed eyes. Treatment given for ROP detected infants. 4 infants belonged to stage 3 zone 2 were treated with laser. 1 infant with AP-ROP treated with anti-VEGF and laser. Coming to discussion, 49 out of 118 babies had ROP in Bhavanahangi et al. Study, which is 41.5%, whereas urban study by Sudha Chowdhury et al. Had 22.3%, which was similar to my study. Most of the babies presented with stage 1 in my study, whereas Anand Vinikar et al. Study had more proportion in stage 3. My study babies were presented with zone 2, which was similar to Anand Vinikar et al. Study. Most of the ROP detected babies fell into a gestational age of 20 to 32 weeks. Newborns with severe ROP belong to less than 28 weeks of gestation. In our study, most of ROP and severe stages occurred in less mature, lower birth weight infant. RDS is a major risk factor associated with the ROP in my study, which was similar to Anand Vinikar et al. Study from South India. In my study, sepsis was found to be statistically significant, which was similar to Hakim et al. Study. Those neonate with sluggish pupillary response and poor dilatation to mydriatics found to have stage 3 ROP with plus disease at time of presentation. Conclusion. My study has concluded that proportion of ROP among preterm newborns is 25% for any stage. There is significant association with RDS and ROP. Serial follow-up of preterm newborns help to detect ROP early. All ROP detected infants on follow-up showed regression by its own or with treatment. These are my references. Thank you.
So you are told zone 2 ROP.
Yes,
Which stage? Which stage is more commonly seen?
Stage 3, sir.
Stage 3. Plus or without plus?
Without plus.
Did you give treatment or not?
Those one baby with AP-ROP we have given.
No, I'm asking you stage 3 in zone 2, did you give treatment or not?
Yes, sir.
Give treatment.
Yes, sir.
What the ET-ROP study report says? Did you follow ET-ROP study reports?
Yes, sir.
Then? See, ET-ROP says zone 2, stage 3 alone you can observe. 3 plus you have to give treatment. This is what ET-ROP study report says. I do not remember. Did you give anti-VEGF also these patients?
Those
Dis-
with APROP stage 3 with plus
Zone-
disease we
zone
have
2.
given.
3 plus.
Yes.
Okay.
Okay, ma. You also mentioned in your title as retinopathy. Basically, don't use abbreviations too much, like CVI, In any study, only the classical abbreviations like DNA, RNA, which are universally accepted, will be taken. That's okay, but it's a good presentation. You said 140 have been screened.
Yes, sir.
No, how many did you screen? How much was the fallout? That is more important, no? In any ROP. What was the fallout rate? How many totally you screened?
140 preterm infants we were screened. Out of that, 35 had ROP.
No. How many you screened? How many did not turn for follow-up? You told no exclusion criteria. If they don't come for follow-up, it was left out of the study.
Yes, sir.
No, what I am interested is what is the fallout rate? Initially, you would have screened 190, 180, out of which 30 would not have come for. Isn't it correct?
Out of 140, only 35 we had correct follow-up, sir.
Oh, the whole data is only for 35 people.
Yes, sir. 35.
But you were telling N is 140 in some of your slides.
140 we were screened. Out of that, 35 had ROP.
Only 18% you said no finding in the first visit.
Sir.
Just check on it. So if the N is 35, then all data will change.
Infants we had 35 and in eyes 70 eyes. So some babies had ROP in one eye, some had didn't have ROP.
So you said 140 eyes,
140 infants.
Infants. So the eyes will be more.
280. Yes.
Somewhere there is some. I'm not sure whether I'm able to follow, but I hope you understand.
Yes.
The N is different from what you are trying to say as 140.
Yes.
Correct. Yes. Okay, ma. Thank you. Good presentation.
Next is Dr. Femida KP, free paper 32.
Good afternoon. Today I am presenting optical coherence tomography patterns in diabetic macular edema among patients with diabetic kidney disease. Objective of the study to determine the OCT patterns observed in DME among patients with DKD. Introduction. OCT plays an important role in identifying various morphological patterns and prognostic biomarker in patients with diabetic macular edema. DKD, one of the most common complications, has similar pathogenesis with diabetic retinopathy. The aim of our study was to recognize if a particular pattern of DME present in patients with DKD, which will help to refer the patient to the nephrologist at the earliest. The study is designed cross-sectional. Study population were patients with type 2 diabetes mellitus with center involving diabetic macular edema who attended July 2022 to June 2024 at a tertiary eye care center. The sample size 104 DKD patients. We also analyzed 22 non-DKD patients. Inclusion criteria: type 2 diabetes mellitus with central involving DME among DKD patients. If bilateral CIDME, the worst eye was selected, and also subject cooperation for OCT and fundus photography, and good quality of OCT scan and adequate media clarity for fundus images. Exclusion criteria: type 1 diabetes mellitus, non-center involving diabetic macular edema, uncontrolled hypertension, laser or ocular surgery or anti-VEGF injection in the preceding 6 months, and pregnancy and other causes of macular edema. Materials and method: after ocular and medical history, complete ophthalmic examination including visual acuity by Snell and Start, which convert to logMAR, IOP by Goldman and applanation tonometry, slit lamp microscopy, fundus examination was done. Investigation: digital mydriatic fundus photography, one disc centered and one macula centered image was selected, and OCT horizontal 6 mm raster scan were selected, and blood investigation where HbA1c, fasting lipid profile and serum creatinine was done, and blood pressure also recorded. Diabetic retinopathy graded into 5 groups by International Classification of Diabetic Retinopathy and DME. Then OCT classified into 5 groups, that is diffuse, cystoid, serous, vitreomacular traction and mixed type. The grading of DKD done by CKD EPI formula, which uses EGFR calculator, which require serum creatine, age and gender of the patient. The result, coming to gender distribution, 65% were males and 35% were females. Age distribution, the most of the patient in an age group of 60 to 70 years, least common age group was 40 to 50 years. The majority of patients had more than 10 years of duration of diabetes, and the severity of diabetic retinopathy, majority of the patient had severe NPDR and moderate NPDR. This chart shows our result, which concluded that in diabetic kidney disease as well as non-diabetic kidney disease, the most common pattern was cystoid macular edema. Discussion. There are few studies about this topic. One retrospective study conducted by Ku et al., who found that cirrus was the most common pattern, and they used albuminuria as a measure of kidney function. Only one Indian study, it was also a retrospective study, who found that the cystoid macular edema was the most common pattern, and they use EGFR as a measure of kidney function. In our study also, we found that the cystoid macular edema was the most common pattern. The strength of our study, it was a prospective study, and we had a control group, though it was very small. And the limitation was sample size small, other biomarkers are not included in our study. EGFR is an inconstant marker, and also confounding factors like duration of diabetes mellitus, systemic risk factor are not eliminated by randomization. In conclusion, the cystoid macular edema is the most common OCT pattern observed in diabetic macular edema patients with a DKD. We also observed that CME is the most common pattern in non-DKD patient as well.
It's a good presentation.
OCT, the grading was Otanit et al. Yes, that. This is from book, this Otani classification. Yes. Not. Estimated glomerular filtration rate.
A general comment to all the students over here. Again and again, we are getting retina pediatrics. Ophthalmology is so vast, and there is neuro-ophthalmology also. There is no paper in neuro-ophthalmology at all. It's a general comment. Yes, sir, but still in this session, in the 17 papers, not even a single paper is there. See, it's a general suggestion. If you do something different, your chances of getting an award is more, right? So neuro-ophthalmology has lot of cases, so many diagnoses are there. So it's a treasure. So you have to explore it. It's a general suggestion.
That doesn't matter. No, all your presentations are good. I'll accept that. You're prepared well. But, to get an award, it should be little bit ahead. That means you must show what is it, how is it different from other existing, at least to an extent. So variation. So what you learn from this. Some people say you need a bigger, or that is the commonest comment. Limitation of the study is the number, because once they announce KSOS, you start your study, within 3 to 6 months you try to finish. It's all right, but you try to show that something new, something very, but don't do anything unethical. With the consent is very good, then the chances of coming to the top level. Can't promise an award, but it will be good. All of you are presenting well. Like example, small things like your abbreviations and all you avoid. You learn, then only you learn to write journals for articles for your journals. Anyway, all the best to all of you. Next one.
Next is Dr. Brinda Ravi, free paper 36.
Good afternoon, everyone. My paper is on the study of etiological factors and ocular features in children with cerebral visual impairment, a hospital-based cross-sectional study. So what is CVI? Cerebral visual impairment is an overarching term covering a wide range of visual and perceptual visual impairments resulting from injury to the retrogeniculate visual pathways and oculomotor control. So how does brain interpret the image? Occipital lobe is mainly the printer, that is, it prints the image we see. Temporal lobe is the visual library and posterior parietal lobe is the mapper and the doer. And from the occipital lobe via the ventral stream, image reaches the temporal lobe, and that is how we recognize the face, objects and shapes. And via the dorsal stream, it reaches the posterior parietal lobe, and it helps in making a 3D internal map of the visual field. In children with cerebral visual impairment, these dorsal stream and ventral stream is damaged. So recently, CVI has become the most common cause of visual impairment in children in developed countries. This is probably due to improved management of the treatable causes of childhood blindness like cataract, glaucoma, retinopathy of prematurity, and improved intensive care of infants and children. In India also, the prevalence of these children is increasing because of the improved perinatal care. So these children will have disorders of eye movement like strabismus, nystagmus, visual field defects. Since it is often difficult to examine such children, some of these issues may be missed. The purpose of our study was to understand common etiology of CVA in our population and common ophthalmic problems that they have. The objective of my study was to identify the etiological factors of cerebral visual impairment in children, to describe the ocular features of CVA in children, and to study the visual evoked potential in children with cerebral visual impairment. Materials and methods. Review of children with a diagnosis of cerebral visual impairment in the age group of 1 to 5 years at Department of Ophthalmology, Regional Early Intervention Center, Government Medical College, Thrissur, from a time period of 2022 to 2023. Inclusion criteria: children aged 1 to 5 years with confirmed diagnosis of CVI. Exclusion criteria: children with profound visual loss due to congenital cataract, glaucoma, or any other ocular pathologies. Sample size was calculated based on the study by Khetpal V, and it was found to be 59. Study tools: pre-tested semi-structured questionnaire, pen torch, illuminated toy, retinoscope, direct and indirect ophthalmoscope, MRI records, and VP. Visual function was assessed by Leah's paddles for preferential looking test, Leah's symbol chart for preschoolers, and colored lighted toy, and using Leah puzzle, Leah mailbox, hiding headache contrast sensitivity charts. Visual function was then graded from 1 to 6. Diagnosis of CVI was made when the ophthalmological findings did not explain the visual performance of the child and there was associated neurological pathology. Study procedure: using a semi-structured questionnaire, all the information and the histories were collected, their medical records were analyzed to determine the cause of illness, and the child's visual function was evaluated and graded from level 1 to 6. The pupillary reaction was checked, strabismus and nystagmus was checked, fundus examination was done, and cycloplegic refraction, MRI records, and VEP was analyzed. Results: there was no significant difference in the number of children in the socioeconomic status. Age group 2 to 3 years old children were the most common among our study group. Etiology: postnatal hypoxia was the most common cause, followed by perinatal hypoxia, seizures, preterm birth, hypoglycemia, infections, and hydrocephalus. Antenatal history: for few of the mothers had intrauterine infection, intrauterine drug exposure, and trauma. Systemic illness of mother: majority of the mothers did not have associated systemic illness. A few had gestational diabetes mellitus, some were over diabetic, and few had pregnancy-induced hypertension. Out of the 59 children we studied, 23 were preterm with low birth weight. Developmental history: 56 of them had delayed milestones, 18 had physical disability, and 8 had hearing disability. Neurological finding: the most common one was microcephaly, followed by cerebral palsy and autism. Strabismus exotropia was the most common type. Nystagmus was found in 19 of them. Refractive error: symbol hypermetropia was the most common, followed by hypermetropic astigmatism and mixed astigmatism. Visual function: most of the children who attended had profound visual loss and showed occasional fixation with no following. Fundus examination was normal in majority of them. VP was abnormal in 15 of them.
And the MRI records, most of them had periventricular leukomalacia followed by hypoxic ischemic encephalopathy. So to conclude, the most common cause of CVA was found to be hypoxic ischemic encephalopathy and periventricular leukomalacia, mainly due to postnatal hypoxia in our study. Majority of the children who came to our clinic had profound cerebral visual impairment and had very poor visual function. Some of the causes like neonatal hypoglycemia can be detected and treated early so that CVA can be prevented in them. Children who had a stormy perinatal and postnatal period should be in regular follow-up, which can be combined with ROP follow-up, and if there are signs of visual function deficit, MRI is indicated. If CVA can be detected early, such children can be visually rehabilitated accordingly, and this needs a teamwork consisting of the treating pediatrician, gynecologist, ophthalmologist, vision therapist, and the parents. In view of increase in the prevalence of CVI, there is a need to include special training of evaluation of these children as an integral part of postgraduate and fellowship training program. These are my references. Thank you.
You have included neuro at least as a brain. That's what sir is telling. Okay. Okay, ma. Why did you exclude cataract and glaucoma?
That is to differentiate cerebral visual impairment from ocular visual impairment. Those are the causes of OVI.
They could be super error also.
Yes, sir.
Thank you.
Thank you, sir.
Next is Dr. Srinidhi PK, free paper 39.
A fine good afternoon all. Today my topic is changes in macular thickness following PRP for diabetic retinopathy. Coming to introduction, diabetes mellitus remain one of the most prevalent and important non-infectious causes of morbidity and mortality worldwide. Diabetic retinopathy represents microvascular end organ damage as a result of diabetes and ranges from non-proliferative diabetic retinopathy and its stages to proliferative diabetic retinopathy. Proliferative diabetic retinopathy affects about 5 to 10% of diabetic population. Panretinal photocoagulation is considered as the gold standard treatment of PDR after several studies. Coming to the objective of my study, to study changes in macular thickness following PRP in patients with PDR without clinically significant macular edema to get an additional insight to laser therapy in our setting. Coming to methodology, it is a prospective study conducted in Department of Ophthalmology, Government Medical College, Kottayam for a period of 1 year and included total of 120 eyes. Coming to inclusion criteria, all patients diagnosed with the PDR who were advised to PRP. Then coming to exclusion, diabetic retinopathy with the CSME on 90-day slit lamp biomicroscopy examination. Then diabetic retinopathy with the central macular thickness more than 300 microns on OCT. Then patients with the other retinal vascular disorders. Then history of intravitreal drug use in last 4 months. Coming to study procedure, patients satisfying inclusion and exclusion criteria were selected. For all cases, central macular thickness and morphology was measured by OCT. Then PRP was done with frequency double ND-YAG lasers according to standard protocol. Each session was carried out in each eye in 3 to 4 sittings and completed over a period of 4 to 6 weeks. Then macular thickness and morphology by SD-OCT was again done at 1 month, 3 months and 6 months after completion of PRP. Then coming to results, the mean age of population was 50 years with a standard deviation of 7.75 years. Then coming to the diagnosis part, 96 eyes were diagnosed with non-high risk proliferative diabetic retinopathy and 24 eyes with high risk PDR. Then coming to the distribution of study population based on total number of burns, 96 eyes were given a total number of burns in the range of 1200 to 1600 and 24 eyes in the range of more than 1600. Then coming to mean central foveal thickness before and after treatment, here we can see in all treatment group initially in pre-treatment group, the mean central foveal thickness was 224, which is increased to 240 after 1 month, and it decreased to 232 after 3 months, and again decreased to 225 after 6 month follow-up. Then coming to OCT morphological features, in majority of patients, OCT morphology was normal, followed by spongiform edema. Then coming to discussion, there was no statistically significant difference in central macular thickness between pre-treatment level and at 6 months from my study. In a study conducted by Mustafa Said Ahmed et al. For the assessment of effect of panretinal photocoagulation on macular thickness in eyes with proliferative diabetic retinopathy without clinically significant macular edema, it was shown that the post-laser macular thickness increased at 3 months, which was statistically significant and correlated with my study. Then coming to conclusion, the study concluded that PRP may cause a temporary increase in macular thickness in patients undergoing treatment for diabetic retinopathy. A well-done PRP reduces VEGF concentration in vitreous and in around 3 months offsets the macular edema induced by PRP in initial weeks. PRP by itself can aggravate a VMD or induce it in patients with a strong vitreomacular adhesion. Coming to recommendation, concurrent use of anti-VEGF along with the initiation of PRP should be judiciously considered for patients with PDR and macular edema, especially in Indian scenario where most patients can't afford multiple anti-VEGF injection. The potential benefits of anti-VEGF injection should always be weighed in patients with PDR and vitreomacular adhesions, as both intravitreal injections and PRP can exacerbate VMT. These are my references. Thank you.
Why did you exclude plus 90 diopter lens investigation?
What, sir?
You have excluded plus 90 diopter biomicroscopy.
Clinically significant macular edema cases were excluded.
You have excluded. Why? Any reason for that?
We are not including.
No, you have excluded.
Yeah, sir.
Why?
We are taking only patients with no significant macular edema cases. That's why.
You want to show that PRP also can cause little bit of macular edema and then.
Yeah, sir. It again decreased to pre-treatment level.
But what if the patient develops the CME?
In that cases, those patients who developed macular edema, we had to exclude from the study and advised for intravitreal anti-VEGF. 4 to 6 weeks, sir. Ah, sir.
They may develop a CME also. You need to have a longer follow-up also to say whether the CME is developing CME or due to the laser. Good.
Thank you, sir.
Next is Dr. Winnie Joy, free paper 53.
Good afternoon, everyone. My study is on visual acuity and retinal morphological changes following retinal detachment surgeries. So, retinal detachment, recmatogenous retinal detachment is the most common type of retinal detachment with an annual incidence of rate of 6.9 to 18.2 per 1 lakh person. It develops when there is a retinal break or full thickness defect in the neurosensory retina and the fluid ingresses into the subretinal space, resulting in separation of the neurosensory retina and the underlying RP. Recmatogenous retinal detachment is primarily treated with either scleral buckling, pars plana vitrectomy, pneumoretinopexy, or combined vitrectomy and scleral buckling. Intraocular gases are important in managing RRD with vitrectomy, as they allow closure of retinal breaks until a permanent chororetinal adhesion develops. Fundus autofluorescence, or FAF, is a retinal imaging modality used in clinical practice which is non-invasive to provide a density map of lipofusion, the predominant ocular fluorophore in the retinal pigment epithelium. And optical coherence tomography, or OCT, is also a non-invasive in vivo imaging modality that allows for the differentiation of retinal layers and visualization of microstructures. So, the aim of the study is to explain the visual outcome following retinal detachment surgery based on morphological patterns studied with the help of fundus autofluorescence and optical coherence tomography. The objective include to assess the postoperative visual outcome, to assess the morphological changes in the retina using fundus autofluorescence and optical coherence tomography at 1 week and 1 month postoperative visits, and to correlate the reattachment pattern with the final visual outcome. Study site is a tertiary eye care hospital in North Kerala. Study population: all cases undergoing retinal detachment surgery, either pars plana vitrectomy or scleral buckling or pneumoretinopexy for macula of rhegmatogenous retinal detachments. Study design is a prospective observational study. Time frame: the study is done for a period of 6 months and the sample size is 68 eyes. Inclusion criteria: patients above 18 years of age who are able to give consent, presenting with primary rhegmatogenous retinal detachment, who have undergone pars plana vitrectomy or scleral buckling or pneumoretinopexy. Exclusion criteria include patients having proliferative vitreoretinopathy changes grade B or worse, patients with already pre-existing ocular diseases like glaucoma, diabetic retinopathy, etc., patients with history of previous retinal surgery or resurgeries, high myopes, patients with media opacities, and other postoperative complications impairing vision. Methodology: the enrolled patients underwent a baseline evaluation that include detailed history, best corrected visual acuity using ETDRS chart, dilated fundus examination with 90-degree lens and indirect ophthalmoscopy. These patients were informed about the procedure in detail, and visual acuity, fundus autofluorescence and optical coherence tomography were done at 1 week and 1 month postoperative visits, and the data was collected, tabulated and analyzed. In this study, variables were taken for 0 to 1 months and was calculated using student t-test. Coming to the observation and results: age distribution: majority of the patients were in the age group of 61 to 70 years, 11.4% were above 70 years, and the average age was 57.6 plus or minus 11.7 years, which was consistent with studies by Delomo et al. And Brosh et al. Gender distribution: the studies showed a male predominance with 68.6% being male, and this aligns with the findings of study done by Williamson et al. Duration of the symptom was also studied. The mean duration is 1.3 plus or minus 0.8 weeks with the range from 0.3 to 4 weeks. Previous studies suggest that longer duration of preoperative macular detachments are linked with poor visual outcome. D. Laura et al. Also reported an average symptom to surgery duration of 13.3 plus or minus 4.9 days. Coming to best corrected visual acuity: baseline preoperative best corrected visual acuity in logMAR was 1.885 plus or minus 0.803, and the postoperative visual acuity at 1 week was 1.765 plus or minus 0.611, and at 1 month was 0.918 plus or minus 0.561. This shows a progressive improvement in visual acuity at each follow-ups. Coming to the clinical parameters: all patients had well attached retina on clinical examination in 1 week and 1 month postoperative visit, and in optical coherence tomography, 21 patients at 1 week had an inner segment outer segment abnormality in the OCT, who also had poor postoperative visual acuity. Similar to the 1 week postoperative visit, at 1 month also 18 patients had ISOS abnormalities, who also have poor postoperative visual outcome. Specificity for the comparison was 100, as all patients with ISOS abnormalities had poor visual outcome, but the sensitivity was less. Similarly, positive predictive value was also 100, which indicates that the chance of poor visual outcome in patients with ISOS abnormality is high. At 1 week follow-up in our study, when we compared the preoperative visual acuity with the ISOS abnormalities, it suggested that poor preoperative visual acuity and ISOS abnormalities at 1 week also has a positive correlation. Persistent subretinal fluid also was noticed at 1 week and 1 month visits, and it was also correlating with their best corrected visual acuity. We couldn't find any fundus autofluorescence findings. So the conclusion is, patients who have not attained good postoperative visual outcome after the retinal detachment surgery, there can be microstructural changes, and the most significant change was inner segment outer segment abnormality, which was correlating with their suboptimal visual acuity of the patient. These are my recommendations. These are my references. Thank you. Thank you, sir.
Next is Dr. Aparna S. Free paper 60. Apsara S. Sorry.
Good afternoon, all. Our study is on retinal capillary macroaneurysm in chronic diabetic macular edema, response to various treatment modalities. Diabetic maculopathy is most common cause of visual impairment in diabetic patient. Chronic diabetic macular edema is defined as macular edema persisting for more than 6 months without any treatment or more than or equal to 6 months even with anti-VEGF therapy. Microaneurysms are the most common finding in diabetic retinopathy with size smaller than 100 microns. The large aneurysmal dilatation of retinal capillaries are called retinal capillary macroaneurysm or RCMA with a size ranging from 100 to 300 microns, which leaks and cause refractory maculopathy. Our study is to assess the efficacy of various treatment modalities for retinal capillary macroaneurysm in chronic diabetic macular edema with respect to visual acuity, central foveal thickness, and size of retinal capillary macroaneurysm. It's a prospective study conducted in 50 eyes of 39 patients from January 2023 to March 2024. The patients with RCMA in diabetic macular edema treated with various treatment modalities including intravitreal pharmacotherapy, either anti-VEGF or dexamethasone implant with or without focal laser. The patient were assigned to different modalities based on their response to any previous treatment and location of macroaneurysm, whether it is center involving or not. The macroaneurysm within 500 microns of foveal center were excluded from focal laser, and the retreatment was given in case of recurrence of macular edema during follow-up. The injections were given on PRN basis. The data analyzed are logMAR visual acuity, central foveal thickness in microns, and size of retinal capillary macroaneurysm in microns at baseline 3 months and 6 months. This central foveal thickness and size of RCMA were measured using manual caliper tool in STOCT Heidelberg Spectralis. The study group include retinal capillary macroaneurysm of size greater than 100 microns and those located within the arcade. Both the treatment naive and newly treated patients were taken, and the aneurysm of size smaller than 100 microns and those present at or beyond were excluded, and other retinal vascular disorders are also excluded. 80% of our study group received intravitreal pharmacotherapy, out of which 54% received pharmacotherapy alone and 46% received focal laser without pharmacotherapy. Average number of anti-VEGF received during the study period is 2.06 and dexamethasone implant was 1.16. 36% of the study group have single retinal capillary macroaneurysm and 64% had multiple retinal capillary macroaneurysm. At the end of 6 months, the visual acuity stabilized in all groups except anti-VEGF monotherapy group. Similarly, as in the visual acuity, the central foveal thickness reduced in the all group except anti-VEGF monotherapy group. The size of RCMA response very minimal with anti-VEGF therapy, and the response was good with laser was applied alone or in combination with pharmacotherapy. This is the pre and post treatment picture. The second picture showing the involution of retinal capillary macroaneurysm following targeted focal laser. This is the pre and post treatment picture. The second picture showing resolution of edema and involution of retinal capillary macroaneurysm following intravitreal dexamethasone with a focal laser. And our study is a large study on RCMA on chronic diabetic macular edema, and we compared the response of various treatment modalities including the combination therapy of focal laser with the intravitreal pharmacotherapy, and we also documented the good response of laser with respect to stabilization of visual acuity and macular edema. According to Spade et al., the rapid resolution of edema and involution of aneurysm was seen with laser. Swapnil et al. Found that RCMA is an important biomarker of diabetic retinopathy which may not respond to anti-VEGF or steroids but respond well to focal laser. Sagar et al. Showed that the DME secondary to large capillary aneurysm respond well to targeted laser. Pacus et al. Also showed the similar finding. Thus, we conclude that detecting retinal capillary macroaneurysm in diabetic macular edema is essential for customizing treatment approaches And the retinal capillary macroaneurysms are that shows poor response to anti-VEGF therapy, and RCMA respond well to targeted laser. However, only less than 50% of the lesions are amenable for focal laser because of its proximity to the fovea. In the remaining 50% lesion, intravitreal dexamethasone implant is better option than anti-VEGF. And we also found that diabetic macular edema secondary to RCMA showed sustained response to combination therapy of focal laser along with intravitreal pharmacotherapy. These are my references. Thank you.
Why do you say macroaneurysm? Actually, macroaneurysm is supposed to arise from arterioles that usually occurs in hypertension.
Yes, sir.
You are telling capillary. That is depending the size.
Yes, sir. Usually macroaneurysms arise in arterioles, but in other vascular, in the diabetic retinopathy and occlusive vasculopathies, the large aneurysmal dilatation in capillaries are called retinal capillary macroaneurysm.
Retinal capillary macroaneurysm.
Yes, sir. Size larger than 100 microns, mostly 200 to 300, ranging from 200 to 300.
You are going to direct focal laser also for that.
Yes, sir. If it is away from fovea, that is 500 microns away from fovea, because mostly they are resistant to conventional anti-VEGF therapy.
Correct. But what will be the common association if you are looking at arterial macroaneurysm? You have not mentioned about hypertension, no?
No, sir.
That is also equally important, but here for diabetes it's okay. Good. Thank you.
Thanks.
It's a good presentation, and you had showed the pre-treatment and post-treatment OCT also. So that is the way it should be. Good.
Apsara, no?
Next is Dr. Lakshmi S. Kumar, free paper 66.
Good afternoon. My topic is Prevalence and Determinants of Meibomian Gland Dysfunction, a hospital-based cross-sectional study. Introduction. The International Workshop on MGD defined the disease as a chronic, diffuse abnormality of the meibomian glands, commonly characterized by terminal duct obstruction and or quantitative changes in the glandular secretion. It may result in the alteration of the tear film, symptoms of eye irritation, clinically apparent inflammation, and ocular surface disease. Meibomian gland dysfunction is the most under-recognized, underappreciated, and undertreated disease in ophthalmic care. As you all know, ocular surface is key to surgical outcomes. Cataract and refractive surgeries are the most widely performed surgeries nowadays. The final visual result is largely dependent on the status of tear film to which MGD can contribute. Untreated MGD put these patients at risk for infection or inflammation. So, my aim and objectives of the study: primary objective, to estimate the prevalence of dysfunction of meibomian glands in adult patients attending ophthalmology OPD of our tertiary hospital. Secondary objectives, to describe the socio-demographic characteristics of patients with meibomian gland dysfunction and to assess the determinants of meibomian gland dysfunction. Materials and methods. Study design is a hospital-based cross-sectional study. Study area: the study was conducted in ophthalmology OPD of our tertiary care eye hospital. Study population: patients aged 18 years or more who attended ophthalmology OPD for consultation were included in this study. Inclusion and exclusion criteria: inclusion, adult patients more than 18 years of both genders who attended our OPD. Exclusion criteria: Stevens-Johnson syndrome, chemical or radiation injuries, diseases related to lacrimal drainage system, and the patients who did not give consent. Sampling was consecutive sampling. Sample size calculation: based on the previous study done by Hernandez et al., the sample size was 352. Study tools included slit lamp biomicroscopy, ocular surface disease index questionnaire, fluorescein strips, lipid profile, HbA1c, and thyroid profile. Study procedure: patient who came to our routine OPD was examined with slit lamp. Meibomian gland orifice was observed in the eyelids and examined for any plugging, pouting of orifices, loss of cuffing, frothy discharge in at least one eye using slit lamp biomicroscopy. Eyelid margin was noted for thickness, rounding of margins, irregularity, vascularity, loss of lash, trichiasis, and malapposition. Mucocutaneous junction was assessed for androplacement, retroplacement, ridging, and mucosal absorption. In those with MGD features, detailed history taking was done, including all the comorbidities, and then ocular surface disease index questionnaire was given. The Mabum quality score assessment was done by applying digital pressure on the glands. Tear film breakup time, tear film height measurement, and ocular surface grading was done. Patients were investigated for glycated hemoglobin, thyroid function test, and lipid profile. Results of my study: out of 352 patients who came to our OPD, 123 patients has got MGD, which accounts for nearly 34.9%. Coming to socio-demography, habits and comorbidities, in the MGD patients, 61 to 80 age group are more prone for MGD in my study, and males are more prone for meibomian gland dysfunction, and BPL patients, that is below poverty line patients, are more prone for meibomian gland dysfunction. Smoking and alcohol has got a definite association with meibomian gland dysfunction, and the comorbidities included diabetes, hypertension, coronary artery disease, dyslipidemia, thyroid disorder, mental health disorder, and sleep disorder, out of which dyslipidemia is more prominent. And the comparison of characteristics between cases with and without meibomian gland dysfunction: out of this, smoking and alcohol are found to be higher in meibomian gland dysfunction, but there is no significant association with meibomian gland dysfunction. But a significant association was noted with diabetes, hypertension, coronary artery disease, dyslipidemia, sleep disorder, thyroid disorder, and mental health disorder. Symptoms based on OSDI questionnaire: most of the patients presented to me were asymptomatic. Mild dry eye was present in 10 patients, moderate in 15 patients, severe in 29 patients. Distribution of Mabum quality score among meibomian gland dysfunction patients: most of the patients presented with clear fluid only on digital pressure. Objective measurement of ocular surface, which include tear film height measurement: most of the patients with MGD has got tear film height of 1 millimeter. And fluorescent breakup time among MGD patients: majority of meibomian gland dysfunction patients had T-but of 5 to 10 seconds. Less than 5 seconds were noted only in 3 patients. Classification of meibomian gland dysfunction based on ocular surface staining based on Oxford grading system: most of the patients has got no staining. Discussion: prevalence of meibomian gland dysfunction in my study was 34.9%, which is comparable to a meta-analysis done by Hazendasak et al. 35.8% was the global prevalence of meibomian gland dysfunction. Males are affected more when compared to females in my study. This is similar to the Binch-Hung et al. Study. Most of the cases had normal ocular surface, and severe dry eye was noted only in 1/4 of the patients. This is similar to that of the Rebensteiner et al. Study, which showed pure MGD showed lower severity of signs of ocular surface damage. Smoking and alcohol consumption was reported to be higher among MGD cases, but no significant association was noted in my study. Mathurkar et al. Showed significant association between smoking and meibomian gland dysfunction, while Tulasian et al. Showed no significant association. Significant association between MGD and diabetes, hypertension, dyslipidemia, CAD, thyroid disorder, sleep disorder, and mental health disorder was noted. Kaur et al. Showed significant association with diabetes, hyperlipidemia, and sleep disorders. Wang et al. Showed association with thyroid disorder, and Shen et al. Showed significant association with cardiovascular disease. Conclusion: 1/3 of patients attending ophthalmology OPD suffer from meibomian gland dysfunction and showed a significant association with the above mentioned comorbidities. Limitation: it is a single center study, it's a self-reported data, and the recommendations include regular screening of the patients, lifestyle modifications, comprehensive management should be done, and further research has to be done. These are my references, and thank you.
Thank you, ma'am.
Next speaker is Dr. Sheba Susan Das.
Good afternoon, everyone. Presenting a comparative study of the postoperative complications after small incision cataract surgery in diabetic and non-diabetic patients. Our study was aimed to compare the postoperative complications after small incision cataract surgery in diabetic and non-diabetic patients in a tertiary care center in South Kerala. The study was an observational analytical study which was conducted in the Department of Ophthalmology, Dr. SMCSA Medical College Hospital, Karakonam, from December 2022 to October 2023. The study included 2 groups.
The group 1 was patients with type 2 diabetes mellitus undergoing manual small incision cataract surgery. Group 2, patients without type 2 diabetes mellitus undergoing manual small incision cataract surgery. The group 1 included cataract patients with type 2 diabetes mellitus between 40 to 85 year age group attending the ophthalmology OPD and willing to participate in the study, and excluded patients with other ocular pathologies that may affect the postoperative visual acuity. Example, glaucomatous optic neuropathy, corneal pathologies, retinal pathologies apart from diabetic retinopathy. Patients who have undergone other ocular surgeries, patients with traumatic or complicated cataract, and patients with type 1 diabetes mellitus were excluded. Similarly, in group 2, cataract patients without diabetes mellitus between 40 to 85 year age group attending the ophthalmology OPD and willing to participate in the study, and excluded patients with other ocular pathologies that may affect the postoperative visual acuity and who have undergone other ocular surgeries and those with traumatic or complicated cataract. So, our study included total 102 participants, 51 participants in each group. After doing a detailed history and vision assessment, anterior segment evaluation was done, dilated fundus examination was done, and after doing relevant investigations, uncomplicated manual small incision cataract surgery was done. Postoperatively, patients were managed with antibiotics and steroid eye drops as per standard protocol, and patients were discharged on the first postoperative day. And they were followed up in OPD on 1st, 3rd and 6th post-op weeks, and in each visit recorded the visual acuity, clinical examination findings and complications. All the data were collected in the Microsoft Excel sheet, and analysis was done using SPSS software version 21. Analysis was done using chi-square test, and p-value less than 0.05 is considered statistically significant. Coming to the result, in our study, majority of the patients in both the groups belonged to the 56 to 70 year age groups. Males were more than females in our study, and majority of them had immature cataract. Coming to the comparison of postoperative complications in each follow-up. In the first week follow-up visit, we found that 30 patients in the diabetic group and 15 patients in the non-diabetic group were found to have complications, and this was statistically significant. In the third week follow-up, 21 patients in the diabetic group and 10 patients in the non-diabetic group were found to have complication. This was also statistically significant. In the 6-week follow-up, 15 patients in the diabetic group and 7 patients in the non-diabetic group were found to have complication, and this was not statistically significant. And the complications we noted include corneal edema, striate keratopathy, uveitis, pigment dispersion in IOL, and hyphema. And in the first week follow-up, 9 patients in the diabetic group had uveitis, and 4 patients in the non-diabetic group had uveitis, whereas 8 patients in the diabetic group had pigment dispersion and 5 patients in the non-diabetic group had pigment dispersion in IOL. And in the 3 weeks follow-up, the most common complication noted in both the group was pigment dispersion. And in 6-week follow-up, only minimal complication was noted. Pigment dispersion was seen in both groups, and 4 cases of uveitis were seen in diabetic group and 1 case of uveitis was seen in non-diabetic group. Corneal edema was seen in a case of diabetic group. So coming to the discussion part, a similar study was done by Singh et al., which was a prospective study done among 150 diabetic and 150 non-diabetic patients to evaluate the visual outcome and postoperative complications after cataract surgery, and the complications were more commonly noted in diabetics. Similar study, prospective study, was done by Bhaskar et al. Among 200 diabetic and 200 non-diabetic patients. In their study, in 10 days follow-up, striate keratopathy was the most common complication, followed by pigment dispersion, whereas in our study, in diabetic group, pigment dispersion, uveitis followed by pigment dispersion was noted, and in non-diabetic group, pigment dispersion more than uveitis. Similar study done by Kaken et al., which was a prospective comparative study which included 60 diabetic and 60 non-diabetic patients, and complications noted include iritis, corneal edema and pigment dispersion. Similar pattern was noted in our study also. And the study was done by Anupama et al., which was a comparative study to evaluate the postoperative visual outcome and complications. The corneal edema, striate keratopathy, and pigment dispersion were more in diabetic group. Similar pattern was seen in our study also. So to conclude, according to this observational study, postoperative complications are significantly more in diabetics than in non-diabetics. The major limitation was small sample size, and this was a single center based study. These are my references. Thank you.
Thank you, Ma. Your study is on diabetic and non-diabetic. Nowhere in the study I see the duration of diabetes, good sugar, blood sugar or HbA, because it's a study. You have not mentioned, that also makes a difference. You have shown iritis, you have shown some things which can, pre-op and post-op also. So that will be one of the important factors I would look for in this. I hope you follow.
Okay. Yes. Thank you.
See, it's a known fact that diabetics are more prone for infections. What do you want to tell us, that you have to do surgery for non-diabetics or not? Is it diabetics patients can undergo surgery or not? That's what I want to know.
Sure, they can undergo surgery, but we have to take more precautions while doing the preoperative and intraoperative workup.
That is, strict control should be there.
Yes, strict sugar control should be there.
Okay. Because one slide I've seen, diabetics for 30 number, whereas non-diabetic only 41. The gap is only hardly 11. Not a much a drastic difference there.
Okay. Maybe because of the small sample size. Thank you, sir.
Thank you.
Next speaker is Dr. Shafna Hamza, free paper 80.
Good afternoon to all. I'm here to present the study on choroidal thickness changes after vitrectomy and silicone oil tamponade for egmatogenous retinal detachment. So the primary aim of the study was to assess the potential effect of silicone oil tamponade on the choroidal thickness after retinal detachment surgery, and the secondary aim was to evaluate the outer retina for any microstructural changes. So silicone oil was first introduced by Paul Anton Sibitz as an intravitreal implant in the treatment of retinal detachment. Silicone oil are synthetic polymers of polydimethylsiloxanes with a viscosity ranging from 1000 to 10,000 centistokes. But in clinical practice, we use 1000 to 5000 centistokes. So silicone oil is chemically inert, it has a high surface tension and a high viscosity. It provides an excellent tamponade, but prolonged duration of the tamponade may lead to anterior segment complications like oil emulsification, cataract, secondary glaucoma, and so on. So the optimal timing for silicone oil removal is unknown, but many surgeons agree that silicone oil should be removed within 3 to 6 months of its injection to minimize these complications. So we conducted a retrospective study in 20 eyes with acute egmatogenous retinal detachment who were treated with pars plana vitrectomy and 1500 centistokes of silicone oil tamponade. We had excluded patients with glaucoma, diabetic retinopathy, retinal vascular disorders, uveitis, and patients who had undergone any surgery, ocular surgery other than an uncomplicated cataract surgery. So we measured and compared the choroidal thickness at the first, second and third postoperative month using an OCT line scan through the fovea. A manual caliper tool was used for this purpose to measure the choroidal thickness at the subfovea and at points 1500 microns nasal and temporal to the subfovea. An average of these 3 points were taken. We also evaluated the outer retina for any microstructural changes. The ellipsoid zone was defined as the second hyperreflective band above the retinal pigment epithelium. So on comparing the choroidal thickness, we noted that by the third post-op month, it had reduced by 37.95 microns. Also, the outer retina showed microstructure changes in the form of ellipsoid zone disruption in 6 of the study population by the first postoperative month, that increased in number to 9 by the third postoperative month. In the patients with the ellipsoid zone disruption, choroidal thickness, more than 3/4 of them showed a reduction in the choroidal thickness by the third post-op month. The pinhole visual acuity had improved in 14 of the study population, that is 70% by the third post-op month when compared to the first post-op month. This pie diagram shows that in among 9 patients with ellipsoid zone disruption, more than half of them, around 67% of them, had a worsening of the pinhole visual acuity by the 3rd post-op month. Here, I would also like to point out that all the patients with an intact ellipsoid zone had an improvement in their pinhole visual acuity. So, we observed that the coronal thickness had reduced by the 3rd post-op month, which was statistically significant, and our finding was consistent with 2 similar studies that used 1000 centistokes of silicon oil tamponade. First one by Dominic Odrobina et al. In 18 patients with PVR retinal detachment, and the other study was by Al-Shehri et al. In 26 eyes with acute rheumatogenic retinal detachment. In our study, we also noted an increase in the number of cases with ellipsoid zone disruption by the 3rd post-op month, a finding that was consistent with a similar study by Duiguer et al. In patients with acute rheumatogenic retinal detachment treated with 1300 centistokes of silicon oil tamponade. So, choroidal thickness showed a reduction by the 3rd post-op month compared to the 1st month in eyes treated with silicon oil tamponade. A slight increase in the number of cases with ellipsoid zone disruption was also noted by the 3rd post-op month. Most patients, however, showed an improvement in their pinhole visual acuity by this time, particularly patients with an intact ellipsoid zone. So, our study shows that silicon oil removal by around the 3rd post-op month, once the retina is stable, will minimize the structural changes to the retina and choroid and maximize the visual outcome. These are my references. Thank you.
So these are almost in line with the other studies, no? Majority of the
Yes,
studies.
No. You have shown one case of inverse hypopyon. You have seen, no?
Sir?
Inverse hypopyon.
Yes,
You have
sir.
shown hyperolion.
Yes, sir.
It doesn't have inferior iridectomy. Why it was not done? Is it your photo or some other photo?
No, sir. It wasn't our photo. It wasn't our photo.
It's not yours.
No, sir. No, sir.
Not the study photo.
That was not our study photo. Sir. That
In
was
these
just to
kind
show
of
the
presentations, you should have only your original photos.
Okay,
Supposing you are giving a description of the disease, it will be expert. But in your study, mostly you shouldn't. Thank you.
Thank you, sir. Thank you, sir.
Next speaker is Dr. Aparna S. Free paper 99.
Good afternoon. Our study is on the topic of effectiveness of gonioscopy assisted transluminal trabeculotomy, also known as GATT, in control of intraocular pressure when added on to cataract surgery in medically controlled primary open angle glaucoma. So, what is GATT? It is a minimally invasive surgical technique mainly used for primary open angle glaucoma. It creates a direct pathway for aqueous humor to flow out of the eye through the conventional outflow system. About the surgical procedure, after a paracentesis, a microcatheter or a 50 Prolin suture can be inserted into the anterior chamber. After a 1 to 2 mm of goniotomy incision, the distal end of the microcatheter can be advanced to the Schlemm's canal. With the help of a microsurgical forceps, it can be advanced to entire 360 degree of the anterior chamber. So why GATT? The advantages of the GATT over the conventional surgery. It causes rapid and effective reduction of intraocular pressure with minimum tissue trauma and faster recovery. It maintains a good safety profile and lesser complications compared to the conventional surgery. So, aim of our study was to evaluate the effectiveness of GATT combined with cataract surgery over cataract surgery alone in patients with primary open angle glaucoma. We used a randomized control trial using block randomization method, and the study population comprises of the patients with primary open angle glaucoma and cataract coming to our outpatient department and who are willing to undergo cataract surgery combined with GATT. The study group can be divided into experimental group. Those are patients with primary open angle glaucoma on anti-glaucoma medications undergoing combined GATT and cataract surgery. The control group comprises of patients with primary open angle glaucoma who are undergoing cataract surgery alone. Preoperatively, both the groups were evaluated for intraocular pressure, visual field, visual acuity, number and type of topical medications. and post-operatively both these groups are evaluated for the same at first week, first month, third month and 6 months. Visual field only done at 6 months post-operatively and the time period was 1 year. Coming to the results, this table shows the changes of number of medications from the preoperative period and postoperative period among case and control groups. This is a results of the 6 months postoperatively. 14.3% required no medication among case group and 50% required only one anti-glaucoma medication postoperatively at 6 months and 35.7% uses 2 anti-glaucoma medication and none of the patients were using 3 anti-glaucoma medications. So, the change in medication requirement from the preoperative period was statistically significant. This table shows a change of intraocular pressure. The mean preoperative intraocular pressure was 14.4 plus or minus 2.7 millimeter of mercury, which was reduced to 12 plus or minus 3.4 at 6 months postoperatively among case group. This table shows a change of visual acuity. The mean visual acuity was 0.489 plus or minus 0.267 preoperatively, which was improved to 0.136 plus or minus 0.142 postoperatively. Similarly, visual field, which was preoperatively 2.81 plus or minus 8.96, improved to 4.2 plus or minus 4.82 postoperatively. Since both the groups underwent cataract surgery, which is expected to improve visual acuity and visual field. Coming to the discussion, a study by Liu et al. Reported mean preoperative number of medication was 3.2 plus or minus 1 and mean postoperative number of medication was 2.3 plus or minus 1 at the end of 4 years postoperatively. Similarly, a meta-analysis of trabecular procedure by Richer et al., which agrees with our result, showing that incorporating a trabecular procedure into cataract surgery can yield an additional 4 to 9% reduction of intraocular pressure when compared to cataract surgery alone. For patients with open-angle glaucoma, then cataract surgery alone can reduce IOP by 5.4 to 7.6 millimeter of mercury. Or it can potentially eliminate the need for 0.8 to 1 glaucoma medication. By adding a trabecular procedure, IOP may further decrease by about 1.6 to 2.3 millimeter of mercury on an average, equating an additional reduction of 0.4 glaucoma medication. So coming to the conclusion, GAT combined with cataract surgery is a beneficial option for patients with primary open-angle glaucoma and significant cataract, providing better management of glaucoma with potentially fewer medication, which can eliminate the financial burden for the patients. These are my references. Thank you.
You have shown that is the slide. Richard et al. Study agrees with your study. That means you are agreeing with the Richard et al. Hello. Understand now? It is not. You are comparing Richard et al. to you. Something wrong.
No, sir, we observe the same result as that.
That is okay. You have done. He is not agreeing with you.
Yes.
You are trying to agree. See, basically, your meta-analysis doesn't show GAT anywhere. You only say trabecular procedure. Number one. Number two, how did you assign cataract with GAT and only cataract? How was it selected?
Sir, it was by...
Because your criteria is same for both.
Yes, sir. It was done by a block randomization method where the odd numbers are taken as GAT and even numbers as non-GAT.
Sequentially 1, 3,
Yes,
5, 7 like
yes,
that.
Yes, sir.
Okay. But the severity did not have any saying on that, duration and severity.
So we excluded the patients with advanced glaucoma and other glaucomas like pseudo-exfoliation. We have only taken the primary open-angle glaucoma.
No mature cataracts?
No, sir.
Okay. Thank you.
Thank you, sir.
Now we have come to the end of the session. Thank you all. And I would like to thank again. Sorry.
You have?
Sorry, that is Dr. Neha Mariam George, paper number 09.
Good afternoon. My study compares tear film breakup time and mebograde in patients using long-term anti-glaucoma medication. My aim is to find the relationship between tear film breakup time and mebograde among patients using long-term topical anti-glaucoma medications and to determine the effect of long-term topical anti-glaucoma medication on meibomian gland morphology and tear film as evidenced by mebograde and TBUT. Introduction. The active agents and preservatives in the anti-glaucoma medications are found to be decreasing goblet cells and tear secretion. However, the direct and indirect effect of them on meibomian glands are being studied, and it shows that there is a significant association between meibomian gland dropout and long-term anti-glaucoma medication use. Materials and method. I did a cross-sectional study with sample size of 50 patients and non-probability sampling technique was used. Inclusion criteria. Patients who are diagnosed with glaucoma and have been using topical anti-glaucoma medications for more than 6 months period were taken, and patients excluded were those using tear film substitutes and already on meibomian gland disease treatment were excluded. Data collection started after ethics committee approval. Written informed consent was taken from each patient and patient's biodata noted. Slit lamp examination of anterior segment done, and dry eye was quantified with tear film breakup test, and meibomian gland was examined with infrared camera of the autorefractometer. Now mebograde was graded according to this photograph, where grade 0 means 0 to 25% loss of meibomian glands, 26 to 50% loss was graded as grade 1, and grade 2 was 50 to 75% loss, and grade 3 was more than 75% loss. Statistical analysis done using SPSS software version 24 and chi-square test was used. P-value less than 0.05 was considered statistically significant. Coming to the results, 98 eyes of 50 patients were studied. Out of that, 51% of them were males. Now, most common 53.1% patients were using 3 to 4 drops per day. And 38.8% of the patients were using anti-glaucoma medications for 1 to 3 years. 36.7% of the eyes had a tear breakup time less than 5 seconds. And 18.4% had mebograde 3. Now, this is a table showing association between tear breakup time and mebograde. Among the eyes having mebograde 3, 55.6% had a tear breakup time less than 5 seconds. In patients with tear breakup time less than 5 seconds, 38.9% were using medications for 1 to 3 years. In patients with tear breakup time less than 5 seconds, 55.6% of them were using 3 to 4 drops per day. Mebograde 3, 44.4% of patients with mebograde 3 were using medications for 1 to 3 years, and 77.8% with mebograde 3 were using 3 to 4 drops per day. Coming to the discussion, a study by O et al. Studied 103 eyes of primary open-angle glaucoma patients on anti-glaucoma medications for more than 6 months. And 83.5% of the patients were found to have ocular surface disease according to tear breakup time. In my study also, 87.7% were having a dry eye according to the tear breakup time values. A study by Uzun Osmanulu, 70 patients on anti-glaucoma medications were studied who were on medication for more than 1 year, and MGD was detected in 80% of the patients. In my study, 87.8% of the patients were having meibomian gland dropout. In a study by Tabaki et al., 88 eyes of POAG patients were studied for MEBO score and non-invasive TBUT, and there were both monotherapy and multiple drug use affects the parameters of meibomian gland morphology, and similar results were noted in my study also. Limitations: it was a small sample size and had a cross-sectional study design. There was uneven distribution of study subjects among the different study variables, and there was non-uniformity among patients, as some of them were on monotherapy and some were using a combination of anti-glaucoma medication. This also affects the number of drops used. Conclusion: the significant meibomian gland dropout and tear film dysfunction occurs in patients on long-term anti-glaucoma medication, as evidenced by tear breakup time and meibograde. The tear film dysfunction and meibomian gland dropout worsens with increase in duration and dosage of treatment. These are my references. Thank you.
Thank you, Thank you so much.